Hello everyone, if you've ever come across whiplash patients in your career, this video is for you.
Hi, my name's Hugh. I'm a foundation doctor and I work in London. I've just rotated through accident and emergency medicine. One of the most common presentations that A&E departments see in the UK is patients coming in after a motor vehicle collision. Any high-risk motor vehicle collision will result in a patient being assessed by a team that involves an ambulance crew and a senior doctor, and they will make decisions about whether a patient needs their spine to be immobilised and whether they need to have imaging of their C-spine. As an FY2 doctor, however, you may come across lower risk neck injuries after motor vehicle collisions. These patients are often referred to as having whiplash type injuries. I found that I was not confident at assessing these patients. I did a questionnaire to ask my colleagues the same question, and I found that 0% were confident deciding or identifying patients who they thought needed imaging, and 0% were comfortable making decisions about whether they could be safely discharged, even with a low risk injury. Now, it's important to say that accident and emergency medicine is a place where you will have lots of senior help and you will always be encouraged to use that. But having the tools and the knowledge to make independent decisions make work much more rewarding. I'd like to look at two validated assessment tools that are endorsed by the Royal College of Emergency Medicine to try and make us more confident at making those decisions.
This is the Canadian CSpine rule. First of all, is there one high risk factor which would mandate immediate immobilisation? Is the patient over 65 years old? Was there a dangerous mechanism to the road traffic accident? Or is there focal neurology when you examine them? If not, is there one low risk factor which would mean that you could safely assess their ability to rotate their neck? So, was this a simple rear end motor vehicle collision? Or was the patient able to walk at the scene? Or does the patient deny having pain at the scene? Or is there no pain reported by the patient when you examine and palpate their C-spine? If yes, then you can safely assess their neck. So ask them to actively rotate their C-spine 45 degrees left and then right. If they're able to do this, you don't need to immobilise their C-spine and they do not need imaging. This is the Nexus C-spine rule. It consists of 5 questions. If any of the answers are yes, the recommendation is to proceed with immobilisation and imaging of the C-spine. The questions are as follows. Is there any focal neurology on exam? Is there any midline spinal tenderness on exam? Is there an altered level of consciousness? Is there intoxication present? Or is there a distracting injury present?
A&E doctors all over the country use these nearly every day when they're on shift. Next time you're in the A&E department, use them yourself and you'll find that you feel much more confident assessing these patients. Thanks very much for watching. Have a nice day. If you've got any feedback or comments, you can post them below.